some grounding and to do some grounding and introductions of what we're doing today. Then we'll talk a bit about current data and heat alert practices. Then the BU team will share some analysis on heat and health data. We'll have some breakout sessions kind of in smaller groups to have discussions about what the priorities are for future analysis and decisions. And then in the last 15 minutes, we'll do report back and close out. And I think with that, I think I'll turn it over to Sharon. Thank you.
Thanks, Patricia. And thank you all for joining today. I'm seeing in the chat folks joining from public government, from private. I'm seeing from across the state. So Sarita, thank you for joining from the western side of our state. It's really exciting to see a group, and we're really excited to bring you all into conversation to explore this statewide heat and health data. So before we jump into the data, I wanted to offer some context for heat alert practices and the current data that municipalities are using. And I'm going to do this with Greg. I'm going to provide some background that's much more grounded in practice and reflects some research we have been doing through the Lower Mystic Cool Communications Project. And then I'll hand it over to Greg to talk a little bit more about the research landscape at a higher level. And we're sort of seeing today's conversation fitting into both of those conversations. So first, the Lower Mystic Cool Communications Project is one of the driving forces behind us connecting with BU and exploring this analysis of heat and health data. Specifically, this project came out of the recognition that it is getting hotter in New England in general. And our cities, especially the cities in the Lower Mystic region in the greater Boston area, are even hotter than the state as a whole. And what we were seeing is that we have a really advanced sort of culture of cold in New England. People know what to do when it snows. We see, we get alerts from our municipality that there's a snowstorm on the horizon and we need to move our cars, and we go out and buy ice. You know the routine. But we didn't have the same culture when it came to summer. And so this project sort of boiled out of the desire to take a first attempt at exploring what would it look like to build that culture of heat in Massachusetts. We are beginning with the 5 communities in Lower Mystic, namely Revere, Chelsea, Winthrop, Malden, and Everett, but really feel that the resources and the research that we're doing for this project have a broad applicability across the state, because urban heat islands aren't happening in these 5 communities alone. And the issues of connecting research to practice and improving communications and networks with the municipalities, community groups, and residents is something that we sort of see popping up across our region, across our state. So as part of this Lower Mystic project, it began with diving in with some of those community groups. Some of them are on the call today, so hello, thank you. The municipalities and the staff who do heat and climate and public health emergency work, and some healthcare systems in this region, who I also see today on this call, so thank you all for joining us. And we asked them, when you were thinking about your heat response protocols, your strategies, what are the sources of information that you were looking to say like, okay, it's time? And the answers fell into these 5 buckets, with National Weather Service and Climate Central real-time climate alerts both being more national level sources of information. Massachusetts Emergency Management Agency, or MEMA, notifications, and the Health and Homeland Alert Network System being a statewide resource. And then the city and town emergency notifications being what people are looking to at the hyper-local level. And I'll note here that National Weather Service, there's 5 buckets, but really I see the National Weather Service being one that a lot of these tie back to. This is the federal group who is issuing heat watches, warning, and advisories. They are sharing that via their vast media networks that are what pushes alerts to your phone to tell you in your weather app that it's a heat emergency today, and also what your local news channel is looking to when they start reporting that there's going to be a heat event on the horizon. They also have the ability to push alerts on cell phones, as does MEMA. However, we haven't seen that really being used for heat, at least not in this region, up to this date. And so I will note, not only is this sort of the source that, for example, if I go back, those local city and town emergency notifications are pulling from, MEMA is also pulling from it, although they do have their own sort of system of notifications, social media, and they sort of like the source that we're referencing back to. So in our review for this project, we found that most city and towns, they are turning to the National Weather Service alerts or local news reporting on National Weather Service reports to trigger their local heat response actions. However, when we asked residents or community groups, how are you finding out about heat? They are then turning to those city, town emergency notifications. And that's your code red, your ready SOS. And these are local alerts that are about severe weather emergencies and community notices. They might know you about like a parade in your area where there'll be closings, or they might be letting you know that there's like a flood warning in your area. And I will note that these are controlled community by community. So you may live in a community where heat is currently included in those emergency notifications, but you may be in a community where they don't currently include heat as one of those severe weather events that they're sending out notifications about. We also found that non-governmental groups are relying on the Climate Central alerts. And this is a nonprofit that does sort of email alerts when weather in your area is reaching a certain threshold. And it's marrying alerts with context. I will note here that the Health and Homeland Alert Network system is also one that we know that public health departments in our state receive. And this here is noting when there is a dangerous heat warning or heat that's unsafe to your health, but to a much more narrow scope of audience. So it's public health departments and some large hospital systems. So that was sort of the landscape that we discovered when we looked at the Lower Mystic of how are you getting your heat information and tying it to your local response. Since we have a larger audience today, we would love to get a sense from the folks in the room. Which of these alert systems, if any, have you used in the past and that you tie your heat work to? And we're about to open a Zoom poll, but if it's one of maybe it's a system I didn't just mention, and we'd love to hear about that as well. So you should see on your screen a Zoom poll that just popped up that asks which of these alert systems, if any, have you used in the past? Give it a second for results to come in. Answers are sort of slowing down, but right now we'll show the results in a second, but I'm seeing National Weather Service and city and town emergency notifications taking the lead. I'm also seeing a couple people choosing other. I would love to see in this chat, what are those other sources of heat alert or information that you are pulling on in your work to do your heat response protocols? Yeah, John notes that some cities without their own heat alert systems often follow what the city of Boston puts out. It's a good point. City of Boston has their own threshold at which they're putting out alert systems different than the National Weather Services. And Jose notes that they amplify city information about emergency practices and resources. So not necessarily those text messages, but the city messaging in general. Radoshi, do you mind closing the poll so that folks can see the results? Oh, he might be sharing right now. So this is interesting, and I think that it reflects a lot of what we saw when we were talking to folks, where really those two the big notification systems that people are turning to is National Weather Service and those hyper local notifications. But that all of these, the HAN system, MEMA notifications, the Climate Central real-time alerts, and some of these other sources mentioned in the chat are playing a role as well. And why I wanted to ground us into it is a little bit what John, you just provided a bridge to in the chat, is reflecting that all of these services, they have a really important role in the sort of landscape of heat response. And they all are designed to serve a certain purpose. However, as we go today and we explore a little bit more of the heat data for our state, we're inviting you all to think of where are the gaps in what these alert systems and information sources on heat are not telling you, that the data from the heat and health data could fill in the gaps. So we're noting here where the National Weather Service alerts really are playing a huge role in our region. That one of the limitations here is they're designed to serve the region. And that's a really important role that they play, but many communities are experiencing dangerous heat before these alerts are issued. And so they might be getting missed by these alert systems. And that there is an opportunity here, and the example that John shared about the city of Boston points to it, where heat and health data allow us to establish heat response thresholds and protocols that make sense for those more local conditions. So just reiterating that these alerts play an important role, but that there is this opportunity with this more nuanced data to explore both, is there another temperature at which we should start thinking about triggering some of our heat communications and heat response protocols? But also, is there like a population specific approach, certain populations who we're reaching out to? So with that, I might hand it over to Greg to provide a little bit more context around sort of the data landscape outside of sort of the practitioner experience.
All right, great. Thank you, Sharon, and welcome everybody. So my name is Greg Wallenius. I'm a professor of environmental health at Boston University. And by, I guess, my research is focused on, as an environmental epidemiologist, focusing on things like extreme heat and air pollution and its impacts on population health. So today I want to share with you a little bit more about kind of what we know about the National Weather Service heat alert systems, with the goal of basically sharing why it's not sort of a perfect solution or a one-size-fits-all solution, and how it's used in practice across the country. So as we all know, the National Weather Service issues the heat advisories and excessive heat warnings when the criteria vary a little bit from place to place, but mostly it's based on the heat index, which is this combination of temperature and humidity. And when that heat index is forecast to be high, then they issue these either warnings or advisories to provide information that the public can use to protect their health, or communities can use to help protect those at greatest risk. We'll call the warnings and the advisories together as heat alerts. And the big difference between heat advisories and heat warnings is that heat warnings are issued at a higher level of heat index, so for more extreme days of heat, but also the warnings often trigger activation of a local heat response plans, whereas advisories generally do not. So this is important context because there's generally a financial cost on communities to issuing heat warnings, whereas there's generally no cost to issuing a heat advisory. So we can come back to that a little bit later. Often people think that there is a threshold for issuing a heat alert that is sort of well established and must be scientifically based. And I'm going to show you some data to suggest that that's not really true. And so that it's really our responsibility as a region or as a group of communities to figure out what would be best for our region. And really at the national level, the National Weather Service provides local offices with guidance about how and when to issue heat alerts, but these are not specific criteria. This is guidance criteria. So next slide, Sharon. So this is some great work from our colleague Dave Handula, who's in the city of Phoenix. And he mapped out a couple of years ago sort of how often do National Weather Service offices across the country issue either excessive heat warnings or heat advisories. And you can see there that it varies quite a bit by office. Ranging from 0 to 5, all the way up to 20 to 25 alerts per year. And what you can, if you know sort of where the heat distribution in the US is, you'll know that doesn't exactly follow this pattern. So if you go to the next slide, what you can see here is, I'll start with the map or the diagram on the right. So on the x-axis here, you see kind of what is a typical really hot day in each city. So the map on the left shows you the forecast zones. So this is, for instance, in the Boston area, we are the box office is the Boston office in Norton that serves Massachusetts, Rhode Island, and Eastern Connecticut. And so there's National Weather Service sort of regional offices across the country, and they each decide when and where they issue their heat alerts. And so again, back to the diagram on the right, you can see that the x-axis is the level of heat index that represents a typically pretty hot day. And on the y-axis, you can see how many heat alerts they issue on average per year. And so generally places that get hotter issue more heat alerts, but you can see in the dots in blue that there are some places that issue quite a bit more heat alerts than expected for their temperatures. And then there's some dots shown in red are the places which issue a lot fewer heat alerts on average per year as than expected given the temperatures that they get. So this is just to highlight the point that it's not just that hotter places issue lots more heat alerts, is that there's a lot of discretion, even for places of similar weather, there's a lot of discretion, a lot of variability in how many heat alerts local offices will issue. So next slide. We did a study, several years ago now that covered New Hampshire, Maine, and Rhode Island. At the time, we didn't have a close connection to research in Massachusetts. But so in this study, we found that across New England, a day that had a heat index of 95 degrees was associated with about a 7.5% higher risk of emergency department visits compared to a cooler day, say one with 75-degree heat index. And so there's two important aspects of this result. One is that 7.5% higher risk at a heat index of 95 is a lot greater than zero. And so at the time, the National Weather Service in our area was issuing heat alerts, heat warnings when the heat index was higher than 105 degrees, and heat advisories when the heat index was higher than 100 degrees. So what we wanted to show, or what we found with this study and shared with the National Weather Service, is that, in fact, even days below that threshold of 100 degrees were associated with some higher risk of emergency department visits. I won't show you the data, but there was also an increase in risk of death that we found in that study. And the other point is that it actually varies quite a bit from community to community. So here you can see each dot represents the relative risk in a different community in Maine, New Hampshire, or Rhode Island we took as a whole state because its population is relatively small. So you can see that the relative risk, even at that temperature, varies from community to community. And in addition to varying from place to place, we also found that the relative risk at this temperature varies by age and by cause of emergency department visit. Next slide. So with this information and working in partnership with the regional National Weather Service, both the one for the New England region and our local, Boston based office, we were able to collaborate to change the level at which they issued a heat advisory. So in summer 2016, you can see that the whole green area, so all of the Northeast US, ranging from West Virginia all the way to the tip of Maine, really used one set of criteria for issuing heat advisories. And that was, again, when the heat index was forecast to be more than 100 degrees Fahrenheit. And then for summer 2017, they changed that criteria to so that in New England specifically, heat advisories would be issued instead when the forecast heat index was going to be 95 degrees or higher for 2 consecutive days, or 99 degrees for one day. This was a small but important shift, and then it has subsequently been modified again to get rid of that 2 consecutive day criteria. So now currently I understand heat alerts are issued anytime the heat index is forecast to be above 95 degrees. So next slide. So that felt like a really important sort of public health victory, because we said, okay, look, here's the risk we're seeing at lower levels of heat. And we partnered with the local National Weather Service offices, and they agreed and changed policy or at least the guidelines in order to try to protect people at lower temperatures. And one of the challenges is that the question then comes up is, does issuing more heat alerts actually protect people? And so we've done a series of studies that I won't go into today, but I'm happy to talk about, that essentially show that, on 2 days that are similarly hot, one day with a heat warning, one without, about the same number of people die. And about the same number of people go to the hospital. So it's not clear that just issuing more heat alerts is enough to help protect communities from on days of extreme heat. And so one of the conversations that's really important to have is, what do we do on these hot days beyond just warning people of the dangers of extreme heat? So, the summary is that the optimal threshold for issuing heat alerts is not really known. We know that that the risk varies by location, by population, and by local resources. And so maybe the heat warning threshold should as well. We suspect, although we don't have direct evidence, that just warning people is insufficient to actually protect public health. Next slide. So this is really the summary on the left, is that we know extreme heat is harmful in terms of higher rates of death and higher rates of illness and suffering more broadly. Even moderate levels of heat are associated with increased risk of emergency department visits and with death, so we could talk about that. We know that vulnerability varies by personal housing and neighborhood characteristics, as well as timing within the season. And as the world continues to warm, we expect more people to continue to suffer from increasing days of heat. And there's a little bit of a disconnect between sort of what the big scale science shows and what we really need to know to affect policy or practice, is really what are the local health risks, not at a national level or even at a regional level, but in my community. Who, including when or where, are people at greatest risk or most susceptible? What can we actually do to protect the public's health, and how effective are these interventions? And the public health community is really good about doing this in an iterative basis. So we try something new, we see how it works, and we evaluate opportunities for further improvement, and then test it out, see how it works, and continue, etc. So I'll pause there and turn it over to our colleague Chad Milanda, who can present some data local to the Boston metro area.
I wonder, before jumping into the data, is there any sort of questions from the audience on sort of the background, the context that we're sharing this information in?
Yeah, thank you, Sharon. Yeah, I'm happy to take questions now or later if you want to put them in the chat too. I think the key message is that the National Weather Service warnings, although extremely valuable and as shown by Sharon, frequently used, are we shouldn't take them as set in stone, or that it's necessarily the gold standard in terms of when we should be taking action to protect our local communities. Okay. Well, Sharon, maybe we can go on to chat, and then folks just feel free to put questions in the chat, and we'll have time for discussion afterwards as well.
Great. Hi, everyone. My name is Chad Milando. I'm a research scientist at the Boston University School of Public Health. I work in the Center for Climate and Health, and so I work on a lot of the data and research sides of a lot of these different projects. So I'm excited to share some local data and results here today that I hope can help inform local research and advocacy for this project and for others. So the key source of health data that we're looking at in this project are emergency department visits, specifically at the local level. So we worked with the Center for Health Information and Analysis, which collects hospital data from most hospitals in the state. They collect a variety of different data products, but the one we're focused on is emergency department visits that don't result in a long-term outpatient stay or some sort of long period of observation. So this is just you're coming in and you're leaving within 24 hours. Emergency department data like this are really useful for studying the health impacts of acute and chronic exposures. And this has been a useful signal in a lot of different health studies related to temperature. And so I think it's actually a great privilege that we have this information in the state. And it took about 9 months to get access, and I'm sure other people on this call have had a similar experience. So I'm really excited to be able to use this and to share some preliminary results with you all today. A short summary of the data are that there's about 2.5. Oh, so we can go ahead, Sharon. Yeah, thanks. There are about 2.5 million emergency department visits in the state per year. And we're looking at information right now from 2010 to 2023, which means we're working with a data set of approximately 30 million emergency department visits in total. We have this information at the daily level, so every day, like when people are coming in. And the spatial resolution we have is down to the patient zip code, which is actually at a very it's a high level of detail that we can look into. For each encounter or ED visit, we have a lot of information about the date and time, the source of the visit. We have a lot of primary and secondary diagnosis codes that are associated, payer type and status, newborn age and weeks, and many other visit level information, as well as information about patients themselves, age, sex, race, ethnicity, Hispanic, patient experiencing homelessness, and many other factors that can enable specific research questions. So what we're talking about today is, I think, the beginning of what we're looking at with these data. But I think, like Greg was saying, the more tailored we can get for specific things, the more we'll be able to enable specific advocacy for specific populations. So we can keep going. Thanks, Sharon. So for the research the results I'm about to show, I'm going to just walk through the methods quickly. This is sort of a standard template for how we estimate the impact of heat on health. Great, I'm just watching the chat here too. Yeah. So at its core, we're using a regression model to compare days across the summer and to see, on similar days within a zip code or within a city, one where it's hot and one where it's not, are the ED visit rates the same or not? The reason we do this and the reason we compare results within a municipality is that the main source of variation in ED visits then becomes just the heat. So we're not comparing places that have very different geographies or populations or sociodemographic statuses or many other things. So comparing Chelsea to Chelsea through time, comparing Everett to Everett through time means that the main source of variation is just in this case, summertime heat. Another difference or another element of this research is that we're not just looking at emergency room visits that are tagged as heat related via their primary diagnosis code, but we're looking in trends in all cause ED visits. And the reason this is that not all our research, here and other places shows that there are many different types of ED visits that are related to spikes in heat that are not always tagged as such. So sometimes renal disease or other types of mental health outcomes are some, people, we see large spikes in those different outcomes during periods of extreme heat, but they're not always also associated with heat-related diagnosis codes, because those usually are reserved for things like electrolyte, see if you're really dehydrated. So that's a reason why we're looking at all-cause ED visits. And the last part about this regression model is that it has two specific components that are useful for studying heat in this way. The first is that we account for lags in exposure. And what we mean by lags is that your exposure yesterday and the day before matters as well as your exposure today, but probably to a lesser extent. And we don't have to decide ahead of time like what that extent is, but just by saying we're going to separate out your exposure today, yesterday, the day before, that allows us to sort of come up with a measure of the cumulative impact that higher heat over a series of days can have. The other element of this regression model is that it takes into account nonlinear effects. So what we mean by that is that the health impacts related to a day that's 80 degrees, 90 degrees, 100 degrees is likely doesn't go up in a straight line. It probably goes up with a steep curve. And this accounting for nonlinear effects allows us to capture that fact that especially at the tail where we see the most impacts, things are not linear. So with that, I think we can go ahead to the primary result. So I'm going to just take a moment to walk through this graph. And this graph is sort of related to some of the other results that Greg showed, but these are specific for Massachusetts from 2010 through 2019. So on the x-axis, we have the daily maximum temperature, and in future analyses, we'll include the relative humidity, so this will be heat index, but it should be relatively the same. So the x-axis is the daily maximum temperature in Fahrenheit. The y-axis is the relative risk of an emergency department visit. And the way you can read this is if you're comparing 2 days and the ratio between those is 1, that means there's an equal chance of going to emergency room visit on one day versus another. 1.05 means there's a 5% increased chance. 1.1 means there's a 10% increased chance. So what we see on the right side of this graph is that compared to a day that has an average summertime maximum temperature of 75, which is the red circle, as you start to get hotter and hotter above that, the relative risk of an emergency room visit goes up. So I think we can click to the next slide because I have some descriptions. Right, great. So let's say you're looking at a day with a daily maximum temperature of 100 degrees. The relative risk of an emergency room visit, if we go travel up to the curve and then across to the y-axis, is 1.14. This 1.14, or a 14% increase, is standardized to the 75-degree centering point, that red circle. So what this graph means is compared for a day of 100 degrees Fahrenheit compared to a day of 75 degrees Fahrenheit. John, I'm reading your message. My suspicion is that the curves would likely be, relatively similar. There might be minor differences, but that's definitely something we're going to work on sort of moving forwards. And actually, Greg's result from before in New England actually matches up quite nicely with this. If you can roughly see where 95 degrees is and you follow that over, it would probably be somewhere between 1.05 and 1.1, which would be around the 7.5% mark that Greg was looking at before. So it's nice to see some similar results kind of through time in this sense. I think we can keep going, Sharon. And then I'll pause after this. So the final piece of this graph that we would look at is, in terms of thinking about interventions and what we can do on a local level, if you were to add up all the days that have a higher risk, and you were to see what that risk was, you could estimate the total number of ED visits that could be avoided if we reduce the risk on a hot day. And what I specifically mean by that is if we said on a day where it's 100 degrees, you were able to give out air conditioning or, you know, do any of the number of interventions that we're talking about in this project that reduce people's risk to the same as it would be on a much cooler day, you could potentially avoid several thousand emergency room visits across the state. And so the number that we calculate from this red shaded area is approximately 8,500 emergency room visits per year in Massachusetts are potentially avoidable. Okay, Jennifer, I'm reading your comment now as well. Hang on. Boston MBO, we're looking at mobility choices. That's an interesting question. I know that we have some mobility data from other sources. I would have to think about what we could use in CHIA to assess that. I can paste the. Oh, sure. Sorry, Sharon. So the question from Jennifer is, at the Boston MPO, we are looking at how heat impacts mobility choices. If someone chooses to drive instead of walk to a certain location because there's no shade, we're curious if your heat-related metadata from ED visits goes as far as documenting such situations. And John's question earlier was about if we factored in humidity and did heat index. So related to Jennifer's question, I think we do have some information on the source, like where people were coming from. I'm not sure that that would get you as far as knowing why people were making a different choice. So I'd have to think more to think if we could answer a question like that. We have a lot of different data sources as part of a large data repository that Greg and others have put together at the Center for Climate and Health. And I think we have information on mobility and other changes. It's something people in our work look at, but we haven't quite associated with this yet. Yeah, it would be great to talk about. So yeah, thanks for that question. Okay. So I want to just recap the two really important concepts that we just showed on that graph. So the first is this relative risk of 1.14. So again, compared to a reference temperature of 75 degrees Fahrenheit, your average daily maximum, so the average hot day, the risk of an ED visit on a day with a daily maximum temperature of 100 is 14% higher. So 1.14 means 14% higher. And it's really important to know that that's a comparison between a day with 100 and a day with 75. If you change the reference point, that value will change. So that's really important to know. And subsequently, the attributable number of 8,500 is, again, subject to this reference temperature of 75. The number of all-cause ED visits that are associated with temperatures higher than that is 8,500. So if we're looking to reduce the risk on hotter days, this is the pool that we're looking to do. And there's a lot of tools in our toolbox that we can use to do that. So I'm going to walk into each of these in a little more detail in the coming slides. So the first is a question that we really want to know about is the number is for 1.14 is for the whole state, but what about the spatial distribution? How does this vary across municipalities? Some will have a higher risk on hotter days and some will have a lower risk. And that's how you end up with this average across the state. But I think it's important for us to, in terms of enabling more local action to say, like John, you were saying, how different municipalities, sort of sometimes look to Boston and sometimes not. Looking at the more spatial distribution of relative risk can also inform that conversation. So we can go to the next slide. So this is a map at the city and town level of the relative risk of on days with 100 degrees Fahrenheit of daily maximum temperatures, again, compared to that 75. So if we look in the legend, like 1.05, the first bucket is 1.05 to 1.08. So that's a 5 to 8% increase, 8 to 10, 10 to 12, 12 to 15, 15 to 17. And then the white squares are places where there's just not enough emergency room data to create a stable estimate. The other part of this that I want to point out is we've highlighted or put in, slightly darker outlined communities that have a high percentage of the population that lives within census tracts that has environmental justice populations. So these are defined by the language spoken and other criteria. And this sort of follows on the Department of Public Health research in this along a similar field. And you can see that a lot of the darkest areas with the highest risk are clustered in these in places with high populations of environmental justice communities. I think if you go to the next slide, so that's the main take home from this map is that, on hotter days, the risk of an emergency department visit are higher in environmental justice communities. We also want to know, if the risk is higher, but there's not as many people living there, that may not translate to the high number of high attributable number. So the other component of this, not only the relative risk, but we also want to know, like, how is the attributable number changing? So the attributable number of 8,500, we want to know, how does this vary across municipalities? And that's what the next map is going to show. So this map is again shows the distribution of the attributable number, this 8,500, across days with 100 degrees Fahrenheit of daily maximum temperature. Sorry, across the state, on days that are really hot. And you can see again with even more clarity that the impacts are clustered in the communities that have the highest populations of environmental justice communities. So both the relative risk and the number of associated health impacts are highest among communities that have high populations of environmental justice communities, which I think was the all-important take-home of this message. If you go one more slide, Sharon. Thank you. And finally, one of the things that we're additionally looking into, like Greg was mentioning, is, who is it that's most at risk? One of the most relevant factors in heat-related ED visits is age. So we wanted to look at how do the risk vary by age group across the state. And what I want to highlight here is that on a day with 100-degree Fahrenheit maximum, the largest increase in risk of an ED visit occurs for people under 18. This is, and you can see sort of the 1.14 is probably most similar to the middle age group, 18 to 39 and 40 to 64. And I know this result is somewhat different than what it is for mortality, which shows a larger increase in risk for populations older than 64. And there are lots of, and Greg can speak more to this too, reasons why we may see a differing trend in risk when you're looking at mortality versus an emergency department visit. So we're still digging into, different ways to communicate and investigate this result. But yeah, I know that this is, thank you, Sasha and Sharon. I think we were looking at data under, trying to identify which populations are most at risk to, enable different messaging or other intervention types. And we'll continue to look into this more. I believe those are all the slides I have, but I'm happy to take any questions on, I have one more. I have one more slide. So yes, the next steps of this sort of dovetail on what Greg was saying in the end of the previous section, specifically zooming in on how we can do more of this research in Massachusetts. So analysis of cause-specific ED visits, and identifying drivers of this risk. We know that air conditioning use and prevalence may be related, people living in historically red line neighborhoods, payer status. And really what I want to highlight is that, I'm really excited to be part of this project, as are the other researchers at BU. And we'd love to hear more about how we can make these results more applicable and enable more decision-making, in real time this summer and in future summers. So yeah, and John is saying in the chat, in North Carolina, Duke researchers found that outdoor workers in the younger age range in rural areas are the most at risk. So wondering if the age finding relates to younger people being outside. John also points out that Toronto has a new thermal comfort guidelines that are set on UTCI. And yeah, I'm happy to take any questions about this and both here and afterwards. So thank you so much.
See, Marissa, your hand is raised. Go ahead.
Hi, this is great work. I'm Marissa Hammond. I'm co-lead the Environmental Health Center at Boston Children's. I'm Chief Medical Advisor at the Department of Public Health, the Bureau of Climate and Environmental Health. This is great and very synergistic with some of the work that we are doing at this Department of Health that's being led by our environmental epi team. And shout out to Darianne and Mather, who's on the call, and Kate Adams and Alicia Frazier, who's leading the quantitative work of this. So it's great. I know we met earlier around these synergistic efforts. And so just a plug to sort of that this is great that it's synergistic with the work that we have found analyzing similar data sources and really wonderful to look at this work and how it can be applied, both the work we're doing at the state as well as this effort. I just had a question about this follow-up, this relative risk of the ED visit. Is that compared to a day that's 75 degrees Fahrenheit?
Yes, yeah. This map is specifically comparing 100 to 75.
Okay, so just 100, not like 85 or 90 or 95.
Yeah, yeah. You know, if we have those information, right? It's these points are essentially if you just took, you know, the curve we showed before and just took like a salami slice, like right at 100, that's what this value would be, and it, you know, would curve down from there.
That's
But
great.
yeah, this is 100 with 100 compared to 75 is what this graph is showing.
Yeah, it's really impressive. I was wondering if you had sort of differences by controlled for differences by day of week or holiday weekends for ED utilization in the analysis.
Yeah, we have we control for day of week, and then there's in addition sort of a term that accounts for seasonality roughly. So there's a sort of it's a metric that controls for time of year essentially, with some ability to be flexible to, you know, that the fact that things are different in May than they are in June, July, or and these are the data here are subset to be just during the summer. So this is just looking at May through September. I think we would see, you know, if we extended it beyond that, it would be sort of slightly different. But yeah, hopefully that answers your question.
Yeah, really great work.
So Marissa, just to build on what Chad said, so there is good work on a national scale, both from using the FIS data, which is the Pediatric Health Information System that covers, I think, 48 children's hospitals across the US, and from you know, people with health insurance, so using some of the commercial insurance databases that suggest that you know, kids are in fact not just not immune from the impacts of heat, but actually quite at risk. And it's really interesting that often the conversation is about sort of the elderly and how we protect you know the medically vulnerable older individuals, but really in our hands and in, you know, other groups, it just seems that kids are particularly at high risk. And you know, our physician partners can speak more to this, but you know, kids are super interesting because they don't always recognize the symptoms or the importance of taking protective actions. And, you know, I know from my own kids that they're like, yeah, it's hot, but that's okay. I'm still going to go do what I want to do with my friends. And then somebody in the chat said, you know, does this correlate with schools not being air conditioned? I think one of the very interesting analyses to do in this region is that, you know, newer schools are air conditioned because that's required by the finance authority that supports the building of new schools, but most of the older schools are not air conditioned. So like there's an opportunity there to see how that, you know, benefits a community or not beyond sort of the other benefits of air conditioning.
Agreed. As a pediatrician, I very much agree with your sentiments, and I think also the interventions of, you know, drink more water can't always be applied to an infant less than one who can't have water for hydration, etc. So very much agree with your points, and I think it'd be interesting to see the mortality data, which hopefully is not you know, anchored in the younger age range, but I think at least from a healthcare utilization it's an important population to focus on.
Yeah, I think one really important point, and the reason that the mortality data shows different results typically is because it has to do with sort of the absolute risk. So people 65 and over die at higher rates than younger people, and also use the emergency department at higher rates than younger people typically. And so when we think of the relative risk, so the 5 to 17-year-olds use a lot less emergency department visits, and very much less commonly die than, say, the 65 to 79 or 65 plus crowd. So this is why Chad sort of shows both the relative risk and then this attributable number of, like, because it could be that the relative risk is very high in the young population, but because they start from a low baseline risk, that the total number of excess ED visits would be relatively modest. Whereas in the older population, even a small increase in the relative risk can be a really big number because they have such high utilization of ED services anyway.
I'm seeing, Jose, you have a couple of questions in the chat. I'm wondering if you want to come off mute and share some of the thoughts that you had around domestic violence and cultural trends.
Yeah, I was curious about, there's the going to the hospital and those more intensive risks, but I'm also wondering if there are stats about increased behavioral challenges in families where, when you're hot, you're more stressed and more domestic violence or crime or those kinds of things, which cause people to, take action because, they're concerned about that. That was one question, if there's research about that. And then the other thing I was thinking about, given, some people come from very hot climates, is there some pattern of the types of people and where they come from that is interesting, either because I'm just thinking if you're born, let's say, in parts of India where you're used to very, very hot weather and maybe how to navigate, obviously you eat different foods and that kind of thing. If there's anything we can learn from that, either to leverage that, or if people who come here dispense with all that because they're in a new place and it's supposed to be cool here and, we don't have to worry. So, and those may be for future research, but I'm curious.
Yeah, so Chad, I invite you to jump in wherever. So in terms of sort of some of the risk behaviors, hard to know population specific, but there is emerging research that on days of extreme heat, there is in the US, unfortunately, more gun violence. The data aren't perfect and there's not that many studies, but that seems to be a emerging finding. There's also higher risk of suicide that has been documented. Again, not that many studies. And there's in an older population, or in the 18 plus population, so adult population, there's increased emergency department visits for mental health in other data sets. So I think one of the questions that I think is very interesting to look at here is sort of what are the key causes of ED visits that increase on the hottest of days. And we expect to see, particularly in the older population, so older adults, we expect to see a lot of kidney disease and dehydration. So that would be consistent with a lot of the previous work. So primarily kidney disease and dehydration rather than heart disease or respiratory diseases. But, it'd be interesting to see if that's true in this data set as well.
That might be a nice bridge. I'm seeing a couple of questions in here from maybe Laura's of drilling down to the causes of excess ED visits, and noting that this could be helpful for both health system response and prevention. And I'll also note that I want to give chance to answer questions as a group, but that in a few minutes, we'll break out into breakout rooms, and we're actually looking for comments like this exactly to sort of set the ship for our next phase of analysis. So keep in mind what would be helpful to see next, because we want to collect that and use that to inform phase 2 of this work. But handing it back over to you, Greg and Chad, to answer the question.
No, I think we can move to the. I mean, if anybody wants to come off mute and ask a big group question, otherwise we're gonna, as you say, break out into the breakout groups, and that's a really good opportunity to dig into some of these details in a bit more depth, and really want to hear from you of like there's. Chad, as you have seen, is highly skilled and capable with the data. What we really need feedback on is what would be the most interesting next analyses from your perspective, because the whole reason to do this is to really advance the policy and practice in communities, and so we need to hear from the communities what would be most helpful.
Just want to highlight that John also asked in the chat, would it be possible to project this data forward to take into account that there will be more hot days? And we're working on that in this and other projects. So another great question that something we're working on. If you envision, that's one of the nice things about that the graph I showed with the curve, right? Because in your mind, as it gets hotter on the x-axis, you can imagine just sort of projecting that curve upwards, right? And we can, with a projected data set, just do the same thing, the sort of coming up and over like we were showing. So we're working on it, John, and thanks for that great question.
And Rodoshi's going to break us out into breakout rooms in just a second. I wanted to note that there are 2 opportunities here. One is this Lower Mystic Cool Communications grant goes for another year plus. And we have the opportunity to do another phase, to continue to do this heat and health analysis through that grant. So we're looking for your feedback on exactly just like Greg was saying, like what is the most helpful direction for us to head, and helpful both in like, this is a question I've always had in my mind, and I would love with this data set to drill into it more in a Massachusetts context, but also helpful in, like Jen was pointing to, we are doing work around heat mobility. We would love to have a better understanding of how commuting and this heat data are connected. So thinking it both in terms of research goals, but then also in terms of like the work that you're doing day to day and how this data might plug in. And I will also share that as part of the Doris Duke Foundation work, we're looking to set a longer term heat and health research agenda. So you've heard throughout this conversation, Greg and Chad pointing to other data sets, even if those are not necessarily part of the Cool Communications project. And there's an opportunity here to say, like, that's not a question we can answer with this CHIA data set, but it might be an answer that we could plug into with a different set of research groups or data sets. And so we would love to capture both of those. So that's the goal of this breakout room. We have 3 very basic discussion prompts. What surprised you? What information seemed the most helpful? And what else would you like to know? But really happy to let you all guide the conversation. And we're planning to come back together around a good breakout room discussion, no matter what breakout room you're in. We have around 8 minutes left, so we just wanted to talk a little bit about next steps for both this work and the Symposium series. So I'm going to just reshare my screen. And then we don't unfortunately have time to report back, but know that the project team will be meeting internally and comparing conversations across the group to sort of set the direction for this research. I will just plug for the Cool Communications project that's focused in this Lower Mystic area. We are going to be joining the Resilient Mystic Coalition Spring Heat Working Group to share some of the initial communication materials and discuss how this analysis can specifically guide the implementation of those materials. So if you are in the Lower Mystic Watershed region and you want to join those conversations, please reach out to me and Marie-Angélie, who's also on this call, and we can loop you in to that conversation, that meeting. And with that, I'm going to hand it over to Kat to talk us through the rest of the closing.
Great. Thanks everyone for a great lunchtime conversation. This is really great. As we've mentioned briefly, some of this work is also helping to inform an upcoming symposium that we're co-hosting. Oh, I can see your Slack. Upcoming symposium that we're co-hosting with the BU School of Public Health. This is, like we mentioned at the start, is a Doris Duke funded symposium. There's conversations happening all over the US this spring and summer. And so ours is on June 18th. We'll put a link, actually, I'll put the link in the chat to be on the email list. But for the symposium, we're looking to advance the priorities in heat health and resilience research. We're hoping to bring together folks that are, you know, anyone who's kind of working in this sphere, practitioners, researchers, legislators, CBO folks, anyone who's really interested in being part of these conversations. So we're looking to advance and identify research gaps and just further collaborate and continue the conversation like we've been having today. So definitely save the date for June 18th. We'll be sending out more. Yes, this will be an in-person event, like a half day at BU's campus. So if you sign up on the link in the chat, we'll definitely send out more details for that. And then the next slide, this meeting today is also helping to inform the symposium agenda and topics. We are having two more similar conversations in the middle of May. So I believe the link that you used to register for this, you can also for the next two as well. We don't yet have topics, but we will by the end of today or this week. We're really using this space and other groups that we've convened recently to develop the topics for these town halls. So if you've enjoyed this one or want to share it with your colleagues, please join us for those. And again, they'll help inform the ultimate event, which is the symposium in June. So looking forward to that, but please share far and wide. And I think before you all go, there is a QR code and a link. We'd love to kind of hear your feedback on this presentation and help us to learn what worked for you, what didn't, so that we can better kind of host these conversations and events in the future and make them really fruitful for all. So we'd appreciate you taking an exit survey to give us some feedback. And with that, we're all set. Thank you again for joining. And Sharon, anything else, or should we close out?
No, I will just say thank you again.